is taking time to share. वो प्रेम प्रेम दिख रहा है सर, पता नहीं।
Muted.
सर एक ही नहीं सर, एक वेबकैम का एक ही लगाना है और हेडफोन का एक लगाना है।
स्टार्ट शेयरिंग के ऊपर क्लिक कीजिए।
हाँ हाँ सर,
स्टार्ट शेयरिंग के ऊपर
राहुल सर।
हाँ, अभी पीपीटी ओपन कीजिए। मिनिमाइज कीजिए। सुनाई दे रहा है?
हाँ कर दिया, मिनिमाइज कर दिया, कर रहे हैं सर, एक मिनट। हाँ सुनाई दे रहा है। हेलो।
हाँ ओके।
राहुल सर, यू कैन हियर मी नो?
हाँ हाँ, लेकिन वॉइस ब्रेक हो रहा है। आप वाईफाई यूज कर रहे हैं लैन? हेलो मैडम।
सुनाई दे रहा है सर? राहुल सर, हेलो।
हाँ बोलिए। हाँ बोलिए।
स्क्रीन फ्लायर दिख रहा है?
अब तक दिख रहा था, फिर चले गया। स्टॉप शेयरिंग मारे शायद आप।
बट आई एम नॉट एबल टू सी एनीथिंग हियर, ओनली द स्क्रीन। राहुल सर, स्क्रीन दिख रहा है? नहीं
अभी नहीं
नहीं
दिख रहा है,
है,
फिर से चले गया।
शेयरिंग है। दिख रहा है आपको? चेंज हो रहा है? दिख रहा है? अभी दिख रहा है शायद? हाँ अभी दिख रहा है।
नहीं, आके चले गए। आप स्टॉप
हेलो,
शेयरिंग के ऊपर क्लिक किए शायद।
स्टॉप शेयरिंग नहीं क्लिक किए हैं।
हाँ अभी दिख रहा है। हाँ दिख रहा है।
अभी दिख रहा है। इज इट ओके?
ओके ओके
ओके ओके, थैंक यू। आपको सुनाई दे रहा था, लेकिन मेरा प्रॉब्लम वो हो गया सर, मैं यहाँ और कुछ नहीं देख पा रही हूँ। आई एम नॉट एबल टू सी एनीथिंग फ्रॉम हियर अगेन।
शेयर कर दिए तो नहीं कुछ स्मूथ करके शेयर करते अनम्यूट करेंगे फिर म्यूट अनम्यूट आपको कंट्रोल करना
कोई दूसरा लैपटॉप में स्क्रीन शेयर कर देता है ना?
वही तो मैं करती हूँ यहाँ से है ना।
सर आपका लैपटॉप कहाँ है? यहाँ कैसे गया?
यहाँ पे आपको क्लिक करना।
हाँ, अभी आप कहाँ?
रुकिए ना, आप छोड़िए, माउस छोड़िए, मैं बता रहा हूँ।
Good afternoon, madam.
Good afternoon.
Good to see you. I think your voice is clear, and your video is also coming clear, ma'am.
Thank you.
Yeah. Alkananda, can you hear me? Is the voice clear at your end? Mugesh sir, good afternoon. Please unmute. Mugesh sir, your mic is not on. Good afternoon, all the participants. We are just doing the preliminary audio video testing. Please wait. We will start as per the schedule which has been sent to you. Right now, the organizers are just checking the audio and the video outputs. Sucharita, Alkananda, can you please turn on your mics and speak so that we know how the voice clarity is there? I can see Miss Jullianne joining, but her mic is not yet activated. Good afternoon. Good afternoon here, Jullianne. If you are able to hear us, your mic is not activated. Can you please check your audio connections? Jullianne, this is Shilpa. Your mic is not activated if I'm not wrong. Can you please check your audio connections? Alkananda, Sucharita. RC Kolkata staff, are you able to hear us? Okay. Jullianne, I can see your mic is on now. Can you talk something so that we'll be able to know? Yes, I can see you now. Good afternoon.
Good afternoon.
Yeah. So nice to hear your voice. I was a bit tense when your mic was not activated.
I know. I was equally worried. I couldn't hear you. I was panicking.
So I'm so glad to see you and hear your voice. Yes. Yes, the RC Kolkata team, we are waiting to listen to you. Alkananda, I can see you are connected. Mugesh, I can see you connected. Kolkata team, can you please come on board? Mugesh, your mic is not on. Please check your audio connection. Would you like to check the PowerPoint screen sharing once, Prathibha ma'am and Jullianne? Would you like to check once the PowerPoint screen share?
Also.
So in that case, I'll do one thing. Prathibha ma'am, you can go first.
Okay.
Yeah, you can start sharing the screen once, so we know that the PowerPoint is being seen and visible to all.
1 second. Can you see it now?
No, not yet, madam.
No, it's just connecting. 1 sec.
Just in case, let me just tell you, in case you have a difficulty in sharing your PowerPoints, I think the PowerPoints are all with us as a backup. You just have to let us know and we will start sharing it from our end and you can continue explaining. If you just say next, we'll proceed to the next slide. So you don't have to worry in case the PowerPoint doesn't open from your side.
I'm trying to access it, but it's taking some time.
Okay, maybe then I'll. Can you see start sharing?
Yeah.
Yeah. Just click on that.
Yeah, no, it is connecting, but it's taking time to connect.
Okay, okay. Maybe it is.
I think there's so much strength there, whatever.
Okay.
There have been problems, I think, since this morning.
Alkananda and Sucharita, your mics are not activated. Please try and check your audio connection. We see you are connected, but your microphones are all off. They are not active. All the Kolkata team, only one mic is active and that is muted. Please check your audio connection.
Can you see whether my screen is now shared?
Yes,
Ma'am, can you hear me now?
yes,
Am I audible, ma'am?
yes, yes, you are audible, ma. You are audible.
Stop.
Yes, you can stop, madam. Yes.
Yeah. Just take a couple of minutes to talk with them.
Yeah, yeah. Juliana, now can you please start sharing once?
Can you see it?
Yes, yes, I can see it. Right. Now we are good to go. Both the presenters are able to share it. It's a nice thing.
Yeah.
Okay. Alkananda, your mic is again gone. RCK, the system connected with the name RCK, your mic is off. Please unmute and then start speaking so that we know if the voice is audible or not.
Unmuted.
Yes, yes, I can hear you now. Yes, I can also see you, but can you please pull the curtain behind you? The sunlight is obstructing. I mean, it's not a very clear picture. I mean, your video is not very clear. Please pull off the curtains. Sucharita, can you speak?
Hello.
Hello. Alkananda and Sucharita.
Yeah, I unmuted Sucharita. Am I audible now?
Yes, you are audible. Yes.
Yeah.
Mugesh sir, me face me the light పడుతుంది Mugesh sir. కొంచెం మీ సీటింగ్ అరేంజ్మెంట్ కొంచెం చూసుకోండి లైట్ బాగా పడుతుంది. Okay, we are all good with the audio. And also
अपना जो पैसा टूल जो है ये कब हुआ 2014 में बना
Mugesh sir, Mohan sir has not yet connected.
Yeah, I'll just follow it up.
Yeah, is not yet connected. I don't see him connected. Can you please check with him if he is having any difficulty in connecting? I can ask Rahul to call him and assist him into logging in. No, I don't see him. I don't see him in the organizer.
Hello.
I don't see him in the organizers. I don't see him in the
$77 million.
Muted. Unmuted.
Mukesh, Mukesh, can you hear me? Ask Mukesh to sit this side. No? The light is behind him.
Yes, sir. I told him to.
Or ask him to close the curtains completely.
I told him, and now Mugesh's audio is not connected.
Okay.
Prem or Alkananda? कर्टन पूरा बंद कर दीजिए, बहुत ज्यादा लाइट आ रहा है, या तो फिर आप चेयर इस तरफ घुमा लीजिए ताकि लाइट आपके ऊपर ना गिरे।
Welcome.
Psychology, Nitpidarchi Kolkata. Welcome you all for this international webinar on recent trends in understanding and managing autism spectrum disorder, a multidisciplinary approach. This webinar aims at enhancing the knowledge of the participants on the key interventional aspects of children with autism spectrum disorder, that is, behavioral, sensory, and communication. The webinar will focus on understanding the recent trends and advancements in support services for children with autism spectrum disorder. I now invite our officer in charge, Mr. T. Mukesh sir, for the welcome address.
Shilpa Garu, I'm in the same system only. We're able to connect with only one system properly. So I'm also staying in the same system where Alka was there.
Yes,
Please.
yes. You are audible, sir. You are very audible. And
Yes.
yeah, please
Can you
carry
make,
on.
yes. Can you make me as a presenter also? Am I
Yes.
sharing the video? Yeah. Distinguished chief guest, resource persons, participants, a very good afternoon to all of you. It's my great pleasure to welcome our chief guest, Dr. Sukumar sir, who is the organizing secretary of Saksham and respected deputy director, National Institute for Empowerment of Persons with Intellectual Disabilities, Major B.V. Ramkumar sir, all the participants and the eminent speakers from India and abroad for this international webinar on recent trends in understanding and managing children with autism, a multidisciplinary approach. This is the first ever international webinar conducted by NIPID and its regional center Kolkata on the digital platform. in line with the social distancing norms due to the COVID-19 pandemic. It has been found that 1% of the world population has autism spectrum disorders as per the CDC 2014, and the prevalence rate in United States itself is estimated to be 1 in 54 births as per the CDC 2020. Prevalence has increased by 6 to 15% each year from 2002 to 2020 based on the biennial numbers from the CDC. Just decades ago, many people with autism were placed with institutions. Professionals are very less educated about autism than they are today, and specific services and supports were largely non-existent. Research shows that with appropriate services and supports, training and information, children on the autism spectrum will grow, learn, and flourish even at a different developmental rate than others. In view of the above concept, today's webinar is a need of the hour, and NIPID and its regional center has came up with this international webinar. Once again, I welcome one and all for this webinar. Hope we will have a wonderful session ahead. Thank you, everyone.
Thank you, sir. NIPID RC Kolkata extends heartfelt thanks and gratitude to our Deputy Director, Sir, Major B.V. Ramkumar, who took out some of his valuable time from his busy schedule for us. I take this opportunity to invite our Sir, Major B.V. Ramkumar, Deputy Director, NIPID, for the opening address. Over to you, sir.
Yeah, thank you. Good afternoon, everyone. And at the outset, again, I would like to personally welcome our chief guest of the day, Sri Kumar Garu, who's the organizing secretary of Saksham. And here I would like to inform all our participants here that NIPID had been actively collaborating with Saksham in undertaking programs which are more towards empowering the person with disabilities. And for our people who do not know about Saksham, Saksham is a very big voluntary organization. We're doing wonderful job for the person with disabilities. We had the privilege of actually collaborating in 2 national conferences. And I'm sure that we would continue doing these programs. And thank you, Dr. Kumar Garu, for being the chief guest of the day. Also, I would like to warmly welcome all our expert panel speakers of today, Dr. Prathibha Karanth, who needs no introduction in the field and who also happens to be a General Council member, and to Ms. Jullianne Bell, ABA consultant from Ireland. And frankly, we are eager. In fact, I am personally looking at listening to you and your talk from an international perspective, and I'm sure that all our participants would greatly benefit from your talk today. And also Mr. Mohan Gopal, founder director, Spoke Therapy Services, who has been sort of collaborating with our regional center at Kolkata. Coming to autism, as you all know, it's a what you call a spectrum condition that affects people differently and at different varying levels, degrees. So understanding this concept, and I would like to tell about NIPID and its role in addressing and sort of assessment of person with autism. And NIPID had done a lot of work in this area. And earlier, before this new RPWD Act, we were actually undertaking cases of autism, which was an associated problem along with ID. But now that with the new RPWD Act has come and it is a disability per se, we are actually changing our and shifting our endeavors towards addressing and empowering these people. And here I would like to very proudly announce that earlier across the country we were using the CARS test tool for assessment of autism. But NIPID has undertaken a research project along with the Director General Medical Services and has come up with its own tool, Indian tool of assessment of autism, ISA. And this has been gazetted by the government of India, and it is extensively used across the country. The main advantage of ISA is one, it actually is, one which is which actually addresses the socio and environmental conditions of this particular area, which is very important in the assessment, and also it gives the percentage of its disability. So we are very proud to have come up with this, and not only this, not only in India, but we get requests from our neighboring countries which actually share a similar socioeconomic conditions like Sri Lanka, Maldives, Bangladesh, and all, requesting us to allow them to use this. And obviously, we are very open and very happy to allow them to use this for the various research programs. Early intervention and early identification of autism, for that matter, any disability, is very important. And as part of this endeavor, I would like to share the recent, initiatives of the government of India. In fact, early intervention has been a very important aspect at NIPID, and addressing the spectrum condition of autism. We have been always emphasizing in trying to create awareness so that not only for prevention but also for early intervention. And this we have been doing through the grassroots level workers to up to the highest level in the government hierarchy as well as the NGOs. Now, in fact, now this government of India is formalizing this early intervention centers by formally setting up 17 early intervention centers.
Welcome.
And yeah, all the very best. Thank you.
Thank you, sir. Today, we are extremely honored to have Dr. Sukumar with us as our chief guest for this webinar. Dr. Sukumar, he is an MBBS from Kurnool Medical College, MD in Pulmonology from SV Medical College, Tirupati, Andhra Pradesh. He is a full-time devotee in various service activities. He is a CMO of a charitable Jai Bharat Hospital, Nellore. He has coordinated various outreach healthcare activities in Andhra. He served Rehabilitation Center for Persons with Multiple Disabilities at Samvedana, Latur, Maharashtra. At present, he is the All India Organizing Secretary of Saksham, a national organization working for the empowerment of persons with disabilities, Divyangjan, based at Nagpur, Maharashtra. Saksham is working for all 21 types of disabilities identified in RPD Act 2016, working in all states and union territories in the areas of education, health, self-reliance, and social development. I invite our chief guest, Dr. Sukumar, for his address in this inaugural session. Over to you, sir. Sukumar, sir, it's over to you.
I think Dr. Sukumar has some difficulty in connecting. Can we just proceed to the next chief guest to speak? Alkananda?
Yes, ma'am.
Yeah. Dr. Sukumar is having some difficulty in connecting.
Yeah, ma'am. Then we will directly get into our technical session.
No, we have, yes. Yes, ma, you can please proceed. Dr. Sukumar is not there right now with us.
So let's begin our technical session for the day. The first resource person for the session is Ms. Jullianne Bell from Ireland. Jullianne Bell is a board certified behavioral analyst, and she worked in the field of behavior analysis for over 20 years in Ireland, India, and USA. In that time, her clinical experience has involved supporting individuals with a range of developmental disabilities and behavioral disorders, aged from 2 years to adulthood in a wide variety of settings. Her most recent experience was as director of a center-based intervention service for children with developmental disabilities in Kolkata. She has experience training both parents and professionals through workshops, seminars, and as a member of teaching staff on the ABA verified course sequence in India. Jullianne is passionate about constantly updating her own knowledge and learning from a wide variety of professionals who are involved in supporting vulnerable populations. A significant portion of her work is also focused on supporting others in updating and growing their knowledge of behavioral analysis in order to better help the populations we serve. I request the participants, if you have any queries, we will take your queries at the end of the session. So, and you can write your questions in the chat box too. It will get answered. Ma'am, Jullianne ma'am, over to you for the session.
Hello. Can you hear me? Just want to confirm.
Yeah, you are loud and clear.
Thank you. Okay. Welcome everybody, and thank you so much for that introduction and for having me here today. It's a real honor, especially with so many diverse speakers. I'm excited for what I'm going to learn today. I'm just going to jump in as time is tight, and I'm just going to start sharing my screen. And 1 second while I do that. Oops. I don't know what I did there. That was not what I meant to do. Okay. Okay. Hopefully someone will let me know if you can't see what is on the screen, but hopefully it's up and running. I can't see you all, so I will just jump in. Okay, so today I was invited to give you a little update on what's happening in the behavior analysis world, and it's specifically its applications to intervention with children or young adults with autistic spectrum disorder. And as the topic today is focused on multidisciplinary approach, also how we can integrate services from different professionals so that we can all work better together. You've already heard about me, so I'm not going to go into all of that. But I have, as it's been mentioned, a lot of years experience now, more than I would like, I think. I can't believe 20 years down the line. And working with complex behavior. Just before I start, actually, I should warn that also the complexities of working from home now is that I do have a few pets, and I sincerely apologize if they make an appearance in the screen. They are closed up, but they're a little loud as well. So let's jump into the main topic. What is behavior analysis? There is many varieties and experiences and knowledge about behavior analysis in the world today. The most important thing probably to know is that it is not specific to an intervention for children with autism. It actually is a science as such in its own right, with a whole range of applications. This is a few keywords. A big guy in the field is somebody called B.F. Skinner, for the psychologists out there. I'm sure you will have heard a little bit about him. The field of behaviorism, though, expands significantly beyond that. So I just wanted to highlight that, because there is sometimes a perception that it is exclusively applied to children with autism, which is a very specific type of intervention, not sort of representative of the whole field, though a major proportion of it. Again, just a brief visual highlighting various ways in which we can think about behavior analysis, but I won't go into this in that much detail. It's not very relevant, but the separation of the science from the service delivery is sometimes an important distinction to make. So, as a behavior scientist, as a behavior analyst, the key thing that I would take away from our concept I would use to describe the field of behavior analysis is that we are particularly interested in what we call a functional analysis, which means that the perception or the assumption is, based on a lot of research, is that behavior happens in a context. And when we understand that context, i.e. the external environment that we all experience, and also the private experience of being in our bodies and all the emotions and the feelings and the illnesses or not, health experiences that we can have inform the behavior we all engage in. And that is how we understand behavior as part of a behavior analytic approach. And that informs then how we approach intervention with children with autism. Okay. With regards to specifically intervention for autistic individuals, I will speak today. That is our topic. And particularly, we'll try to present on how that can be applied. As already we have an occupational therapist speaking, and we have a speech and language therapist speaking. I will try to speak specifically probably to more of behavior reduction. Behavior analysis does include a lot of behavior increase and skill development. I would say in my 20 years, maybe 10-20% has really only been focused on reducing particular concerning behaviors. But I think it is where maybe I can contribute a little bit today, given the breadth of experience that we have in the what's the word, conference that we are attending today. Okay, so key features of today's ABA. ABA is 50 applied behavior analysis and its application to children with autism. It's about 50 years old now, 50 or 60 years old, but it has evolved significantly over those years. The research has evolved, the service and how it's applied with children with autism has evolved. So, few features that are key features, and then I'll briefly talk about sort of a practical application and how this might look. So all key features, all behavior is functional, is a core principle. As I said, behavior, as a behavior analyst, we come from the philosophical position that behavior happens in a context, and it's that context that really shapes the behavior that we all display, not just children with autism. Therefore, when we come to approach and help a child who's maybe having some difficult or concerning behaviors, we'll always come from the position that this behavior is functional. They have learned it for a reason, because of their history, because of the current context. It may not be the best way to communicate what they want to communicate and get their needs met, but it is functional based on their learning history. We always want to approach that, and we believe that approach is respects the dignity of the individual. It's not saying this individual has something wrong with them and we need to fix it. The main principle is that there's a function to this behavior, and we will help them figure out what that is and then get that need met, that function met in a different way. Part of that kind of philosophy also of dignity and respect is that if assent is withdrawn, particularly certainly with adults, they will consent to their own intervention, and with a young child, assent who maybe can't speak, assent may be withdrawn just by showing distress if they can't show it in another way. So we will always honour that they therefore may want to withdraw from whatever intervention we're providing at that minute and reassess their needs. As I already said, the core principle is that behaviour is functional. Therefore, we would never want to reduce a behaviour which is serving a useful function for the individual unless it is dangerous to themselves or others, or severely impacting that individual autistic person's ability to function in the world in which they live and to have a true quality of life. And a big principle and a core principle in achieving all of this part of philosophical approach to behavior analysis is that we eschew the use of punishment as a way of changing behavior. There's just to quote a big, again, who I mentioned earlier, B.F. Skinner, the wording's a little odd, so I'm actually going to just summarize paraphrase the statement, which is that punishment really only acts to suppress behavior. It doesn't remove it, and at best, the individual learns with this person or in this context, I shouldn't do this, and I should avoid, just to avoid punishment, but really doesn't move them forward in life. So we eschew the use of punishment in today's ABA. Okay. So with all of that in mind, I'm going to specifically talk on then one particular approach to reducing any behaviours that are perhaps dangerous, etc. in the field of behaviour analysis at the minute, which has a strong research base, and I thought maybe functional and useful to everybody in the group, as we have many teachers, psychologists, etc. However, just to note that this is kind of at a, I'm just actually going to check the time. This is sort of at a quick rate of moving forward. So it's a very, very brief, rough introduction to the topic. This in no way sort of will give you that many practical applications right away, but I'd be happy to help anybody if they contact me in how to do this in more depth. But just want to give a quick introduction to what we call practical functional assessment or analysis. How do we find out what is that function and then intervene from a behavior analytic perspective? Okay. First thing that we need to do as practitioners and supporting children with autism is listen. So in terms of more technical language, we would call that assessment. And there's many, many ways in which we can gather information which will shape our understanding of why a behavior dangerous behavior is happening, why maybe someone is hurting themselves or experiencing intense meltdowns. So, and the most important way we can do that is through listening. I'm going to come back to that slide actually, because this is maybe more appropriate as part of the listening topic, in that when we are doing that assessment, and as our topic today is multidisciplinary approach, it is essential to listen to as many relevant voices as possible, to try, because the OT, a speech therapist, a special educator, psychologist will have unique assessments, which me as a behaviour analyst won't be familiar with, and they will have ways of understanding and experience that contributes to understanding the needs of the individual in front of us, and assessing and what is the function, what is the need, what is the reason for the behaviour that is happening. Above and beyond that, I would say maybe I should have made it bigger, is if the client themselves can communicate, then they are the biggest, and communicate fluently and analyze to some degree what's going on for them in their internal states. They are a huge source of information which we should lean on heavily to understand, again, why this particular behavior is happening in this context, in this setting, for this individual. If they cannot communicate for themselves, then that's what all of these other professional observation assessment tools will help us with, and also speaking directly with their family. There's something we use called the interview-informed assessment, which really is about spending time with the client or the family, which in depth, really understanding what's going on for the individual. I just wanted to highlight the Autism Self-Advocacy Network in terms of when we think about listening to an autistic person, if we ourselves are not autistic and, as they say, neurotypical, we need to come from a place of understanding the perspective of the autistic community and how they may think and communicate differently. So really getting in touch with autism advocates, etc., is really helpful. And this is one place in which you can, again, assessing and listening and understanding the needs of the individual in front of you. It doesn't give you the very specific individual needs. That's what our in behaviour analysis we call the ecological assessment might do, so assessing all the cultural and social and environmental factors, what your OT assessment might do in terms of sensory needs, etc. But having a broad understanding of what the autistic community is saying about their own experience of the world is going to really help shape and make intervention much more effective and respectful. This is just, when we talk again about function, what we're really talking about is what does an individual need in this situation? What need are they trying to fulfill with this behaviour they're engaging in? And how do we help them do it in a more, let's say, less dangerous, less harmful way, and more that gives them more access to engaging in the wider community. This is just a general summary from Matlov's, I think I'm maybe getting that name wrong, of the original person who kind of summarized the most broad categories of individual needs that any human being will have. So these are helpful for helping us figure out what our kids need. Then, as part of that listening process, it's maybe a little separate from the listening process, but my question then as behaviour analyst is, did I listen well enough? And that's when we do a little brief, what we call functional analysis, our test of what we think is going on for this individual to see, are we right? I won't go into the details of this graph. It's not that complicated, but we've limited time. But the basic principle is that these white circles at the bottom represent what we call the control condition, where we fulfill every need of the individual that we could possibly have understood from our assessment. And in that situation, we want to create a situation in which they have no need, therefore, to engage in any we call maladaptive behavior. So non-adaptive behavior, and therefore we see these white circles are off at a very low rate. So that shows we have a good control or condition. Then our test condition, we will introduce very mild exposure to the situations in which we believe the person experiences a need and that not getting met, whether we might present, in this case, this individual, their behaviors are associated with escape, getting to something tangible. So maybe there's particular demands that are aversive to them. Maybe there are particular items that they generally don't have access to. We will put in some demands, remove some items that are not highly that are part of what we think they need when they communicate using maladaptive behavior, and then see what happens. And in this rather perfect example, the black dots in the test condition, the behavior spiked. As soon as we see the behavior occur, maybe that might be hitting self, it may be screaming loudly, etc., then we immediately go back to our safe space, as we might say, the control condition. Our goal is never to create any sense or exposure to an intense level of need not being met, but a very mild exposure allows us just to test, did I listen well enough? Have I got it right? And be confident going forward in our approach. Next stage is, now I know what need is being met by this particular maladaptive behavior that the person's engaging in. Maybe self-injury, it may be aggression, it may be strong language and such like. I will then move into what we would call the intervention phase. And part of that, though, before we can really go anywhere near the behavior itself and looking to reduce that, is that we need to help them learn by creating joy, as we might call it in everyday speak. In behavioral speak, we may call it pairing or rapport building. And it's very like what I talked about, the control condition. It is, it involves just setting up the world so that their needs are very much met and associating ourselves with those needs being met. So life is good. All needs are met. We associate ourselves with the experience of all needs being met, and we practice to get to know the person, and better even than already we do, and associate ourselves through listening, mirroring, maybe we engage in some stereotypy with them at that time. We relate to and connect with their lived experience in the world. And it can involve many and random things. We all have unusual tastes sometimes in life, and certainly children and adults with autism, because they have that different experience of the world, have some that we maybe wouldn't traditionally have sought to engage in. For example, the examples of the little boy watching the blue lights, the bead activity, lining up items. These are all preferred potential reasons for engaging in maladaptive behavior, which are now being, which we are now going to join them in and learn about. As we move on then, so now we have the need is understood, we have a positive, trusting relationship with the individual that we're working with. We then want to move on to what we call learning by empowering. And the most empowering thing for any individual, I would argue, and I believe, is being able to communicate your own needs functionally to those around you that are supposed to be helping you get those needs met. This is a stage which usually involves teaching some functional communication or replacement behavior. So rather than hitting yourself, how's about you use this visual, this word, this picture, this button, this whatever it is, this alternative behavior in order to get your needs met. And that can be very idiosyncratic to the individual. There is no right or wrong way of doing that. The important thing is that it does need to be understood by the wider community that they interact with, because they need to be able sometimes to help them meet their needs appropriately. So we call this time, we often use at the start, rather than get into trying to teach an individual, because these are dangerous and really significantly impacting behaviors, rather than go into teaching individual meanings of words. We will often start with teaching a generic phrase like my way. So I need my way right now. I can't handle whatever other things are going on in the world. I need things. I need to get this other need that we've already assessed and analysed met. Excuse me. So an individual will use their device, their words, text, their gestures to communicate this. I need my needs met right now. Those needs that you assessed earlier, I need those met right now to be able to be okay. And I will communicate that functionally and appropriately by maybe pointing to myself and saying my way, just vocally saying my way, pointing to a picture that says my way. It doesn't have to be my way. We just try to choose a neutral statement. So we do. Much later down the line, then once maladaptive behavior is reduced and we have a happy, relaxed and engaged person who knows they will be listened to when they say phrases like my way, then we absolutely would need to work with a speech therapist in order to teach what we might say more broader functional language, to be able to tell those who haven't been part of the analysis and haven't been informed what exactly their needs are in various situations. But we start broad. Next phase, learn by compromise. So we understand why behavior is happening and their needs, and that their needs aren't getting met. We understand how to meet those needs, and we've given them a way to get those needs met appropriately, and formed a trusting relationship with the individual. Now that we're there, unfortunately, sadly for all of us, life cannot always be my way. The reality is that we all have to compromise to live in the world and to be as part of a society. If we want to stay to ourselves, that's a choice too. And as part of a good ABA program, a good behavior analytic program, there will always be the choice for the individual to walk away from any kind of intervention. And but we by principle want to make our learning environment so motivating, and it should be motivating to get your needs met and to learn communication. They choose to stay with us. So if they choose to stay with us in learning together, then we do move on to teaching how to compromise. And that usually involves, now we have a replacement behavior for getting needs met, also teaching other alternative behaviors that are required for living in the world that we live in, and getting their needs met. First stage of that is that we will teach basically it means, this stage means saying no whenever a person requests my way. We don't mean no forever, we mean no for a little while. So it involves delay and teaching. Again, when you hear that no and you can't have things my way, alternative way behavior that can, and rewarding that behavior. It might be, okay, whatever, if you've got a slightly, alternative cool dude who doesn't like to just say okay. I was thinking, I've included the visual because it took me a long time to figure it out, but the Indian traditional nods of the head would very well communicate yeah, I'm okay with that. This is my new behavior, that instead of hitting myself, because I trust you, that you understand I have also needs that need to be met. Once again, that behavior is heavily established, and the kid is engaging it, we immediately then remove the need for engaging in other activities. So we're not moving on to other activities right now. We're just taking a time to just establish a way of saying, okay, I understand that right now isn't my way time, and I've heard and listened to you, and we really strengthen that behavior. Now, final stage, we get to the bit that as educators, I think we all love, is we extend the delays and increase adult directions, and that can be anything functional in life. So it can, because, and what tends to happen if we follow this approach is that we basically can reduce those maladaptive behaviors to zero. Maybe sometimes in the middle of brushing teeth, getting dressed, making a bed, a kid will say my way, and they have learned that sometimes it will be, okay, you know what, right now it's not that important to make your bed, let's have your way time because you have a need that needs to be met. And sometimes it might be, no, not right now, and they've learned to say, okay, that's fine, and then to tolerate these other these other activities in their day, knowing and trusting that my way is and will be available in a short time. So, and those, I wonder, how are we doing? Sorry to ask. So basically, yeah, I should sum up that is basically a behavior analytic approach to reducing any maladaptive behavior. It is very broad, what I've just given you. Non-specific looks completely different depending on which kind of child you're working with, what is the behavior that you're looking at, and that's where you need all of those professionals that come in and guide how we what that process looks like. But that's the basic steps. I want to show a video, but I don't know what our time is like, so if you don't mind if I ask some of the hosts to just let me know
Yes, ma'am.
do we have time for a short video clip?
Yeah, ma'am, you can continue with the video.
Okay, so I don't have permission for sharing videos of some of the kids that I personally work with, but I have found some videos of this process happening online. So I'm going to just share a little clip from those to hopefully give you a visual of what this all might look like in practice. A disclaimer would be that I don't work with or haven't been involved with this particular centre. This is a very this is a very unique situation in which it is a residential situation. So these are young adults who have had to move to a residential setting because of the dangerous level of their behavior. Behavior analysts weren't involved at one point, but then got involved a little later, and followed a process similar to this one and helped them acquire some new functional behavior. So I should have had my file open, but I'll get it briefly. I provided the link for where you can see that video, but as it is online, but I just wanted to share. I've just downloaded it so that it plays hopefully a little better. If some of the presenters can jump on and tell me if it's not visible because of network issues, we'll move on, but I will try once and see what happens. The first example is a young boy with his mother actually introducing the video and with a brief example of the type of behavior that he engaged in, and then how they identified some of his preferred activities and introduced some functional communication. Okay, so no video, there's no audio right at the start. I believe it's coming. Yes. Okay, actually not the one I thought it was. 1 second.
Joey was diagnosed pretty early, pretty young, and from early on, we knew that he probably would be on the more severe end of the spectrum. It was clear that he was profoundly affected in every way from his disabilities. Prior to his coming to Tradewinds, Joey had a lot of aggression and self-injurious behavior. And I know, those are words we use a lot. I think I hear them all the time, and I feel like sometimes people don't really know what does that look like, or to what degree does this child display aggression and self-injury. And in our case, Joey was in and out of hospital placement. Any given time I could call the hospital and they considered him acute crisis based on the behavior that he displayed on a daily basis. We had actually leased an apartment to separate our children because we could not have all three of them in the same house due to the level of aggression and the danger that it posed for them. So we were separated as a family prior.
So that's the extreme end, just jumping in to say that's the extreme end of the spectrum, obviously, of behaviors that sometimes are displayed that are dangerous. I would also like to note these are not part of a diagnosis of autism or necessarily specific to autism, but just that those, but they do occur maybe at a higher frequency and need some intervention sometimes. So just
his going residential. We still saw a lot of the aggression, still really had trouble with that. It felt like, we were being careful about the demands we were placing on him, which made me nervous as his mom. There's only so much time.
Just jumping in to explain, this is the, you might say, rapport building stage. It doesn't show the assessment other than the brief one that you've seen before, where clearly demands for this young boy are aversive, and he felt like maybe he wasn't being listened to in order to escape those demands. So, so we're now, is the previous video clip. In this clip, it is the life is good situation, the rapport building. So for him, that's very tangible rewards. His escape, as far as I could understand, was his desire to avoid demands. Was not about the demand or not being willing to work and learn. It was that he wanted, at those times, really wanted to get away from the task in order to get to those things that he loved and felt a need to engage with in that time, maybe for sensory reasons, maybe just because we all need some downtime. And he maybe felt that wasn't being honored previously in his previous settings. So here he is enjoying the things that he enjoys.
I felt like we had left in school to have teams of people help him, and I also felt like he's only getting.
He's also a little further down the road in that they're at the stage of beginning to put in a mild, what you might say, instruction or request, which is that they are just going to ask him to transition to a work setting, and then you'll see him communicate that he wants to leave.
Bigger. So these things have to get worked out. So, I think it was in the past couple of years, particularly this past year when he joined this program, that we really saw gains. And my favorite thing that has happened in the past year since he started your program, my phone rang.
So it seems like such a small thing, but and not that functional at this stage in terms of whole of life can't be like this. But again, this is a situation where previously this young boy, when asked to move from the things that he loves, probably felt that he had no way to communicate and let everyone know that I'm not ready, I need more time, I need my way, and that and trust that that would be honored. So we had to start, or we, it wasn't me, these people, this therapists and his team had to start right at this level of building that trust that we will honour and listen to that need, and we know what you need because you maybe don't have a more broad range of communication. We've done all the work to understand what are your needs, and we'll make sure that those are met. So so that's what's happening there. I think I will stop there. I'll just see, is there...
And I picked up my phone.
I'm just going to skip ahead. There is, then you'll see... this is a video of a demand situation where he's learning. Actually, his mum was very keen that he would learn how to put in his or charge his iPhone or iPad, I guess, so that he could call her if he was ever in a low mood. So they couldn't teach him before because any attempt to teach to around the use of the iPad was extremely aversive to him, and again he didn't trust that his needs would be listened to when he didn't want to be taught and he just wanted to watch his iPad. So in this situation they're now able to do that because he trusts that, okay, they will listen to me when I say, okay, I've understood you, I know how to plug my iPad in, now I just want to chill and watch my iPad. And the mum had the reassurance of knowing that her son could always connect with her whenever he felt he wanted to. And then it just goes on to show, you'll see online, it goes on to show him working in the cafeteria and things. So it did have a significant impact, hopefully, on this young man's quality of life. Just to finish then, there are lots more videos on that particular YouTube site. So feel free to go there and see those. Again, their particular population are all children who have reached a very intense level of self-injurious and dangerous behaviour. It doesn't need to be at that level before we intervene. It shouldn't be, and it's very sad for those young people that it happens so much later in life. But it is, we wouldn't want to intervene at the same time on a behaviour that isn't dangerous to the individual and just something that they enjoy. So, okay. Final sum up is the key is to all of this actually working. I think hopefully behaviour analysts, and you now feel behaviour analysts have something to contribute in the process, in possibly the teaching of the new skills and identifying those new skills, part of the process. But collaboration is essential to actually truly understanding what are the needs of the individuals we're trying to help. And just to acknowledge, this particular talk is based off the work of a researcher and clinician in behaviour analysis called Dr. Greg Hanley. These are linked to his website, in which he provides a huge amount of tutorials, data collection sheets, etc., completely for free. So there's a lot more in depth there that it could be learned. And just some other sites, I'm not going to go into them now, that are useful for learning a bit more about behaviour analysis as it is and should be practiced now. And then just a final note is that for all of us, I think in these 50 years and my 20 years of practice, what I've learned about essential knowledge for an ASD practitioner is some training specific to autism intervention, cultural knowledge, which is why, for example, my 8 years in India, it was essential that I was surrounded by people, local individuals who were actually providing a lot of the intervention and could tell me whenever I was maybe not understanding a cultural behaviour. Developmental knowledge is very important to know what is appropriate at various times. Trauma-informed is discussed now widely in the field and by autistic individuals. It's very important because many experience sort of the reality of being a neurodiverse autistic individual in a very neurotypical world, quite traumatic at times. And so that would come into the phrase, nothing about us without us. So be in touch with the autistic community, and hopefully as part of that, I think knowledge about progressive and evolved science of behavior analysis will really help with that process of helping our kids and young adults. Okay, so that is everything from me. So it is. I really appreciate your time listening to me. I hope I wasn't speaking too fast. I was a little worried about the time, and I know my accent can be a little strange. And I look forward to any questions that you have. Oh, just finally, and perhaps if anybody has any questions, feel free to contact me on my email address. And I'm sure you can, if this is gone and you forget it, you can get it from the organizers at a later date. If by any chance you need anything from me, I'm happy and love actually connecting with other people, professionals and parents, etc., in this world of autism intervention. So I'm just going to stop sharing my screen. And again, thank you so much for all your time and attendance. And I'll take your questions later. Thank you.
Thank you, ma'am. Thank you, ma'am, for your enriching presentation. We will be taking up the question and answer at the end of all the 3 sessions. For the participants, we have some poll questions that will pop up in your screen. You are requested to answer the question. Thank you. Thank you, ma'am.
Thank you.
Dear participants, we have Dr. Sukumar with us now. I really apologize to Dr. Sukumar because of some technical issues. We couldn't have him in the inaugural session. Sir, over to you. We would like to listen from you. Sukumar,
धन्यवाद.
over to
धन्यवाद
you.
बहन जी धन्यवाद. So आदरणीय राम कुमार जी, Saksham has got privilege to work with NIPID thrice or four times. So now it is great pleasure for me to participate in this webinar. And just I heard the lecture of Bell Madam. This is a highly enlightening lecture. I am a social worker. I'm not a professional, but because working in the ground, I got exposure with children with autism and parents and their problems and the ground deficiencies in our country. So this is very good platform to share my ideas. So I once again thank to Mukesh of Regional Center of Calcutta, so for giving me an opportunity to share with all of you. So the basic 2-3 things in my mind regarding autism related to our country, because still there is so many problems regarding awareness in professionals also, and even pediatricians also cannot diagnose autism properly, and lack of occupational therapists, psychiatrists, there's very big problem. So only limited to some big centers and national institutes like this. So autism incidence is increasing 1 in 60 like that, and I think NIPID is already doing NIPID. So we have to work out for indigenous methods for rehabilitation. So mainly focusing on areas. So then only we can go ahead. So our Kozhikode Calicut district president is there, Mohan. He is father of a autistic child, Kedar. I met his mother, father. He was hyperactive child, the tantrums. But after identifying the capability of music in him, they made him to learn the drums. So he learned drums very well, and now he is employed in a temple. He beats the temple drums. He is earning. Now he is quite peaceful, and he is highly cooperative. Like that, so many things are there. So what I feel is, I request Ram Kumar ji and other experts in this. Let us have a registry of best practices or experiences of the parents. So that will be more useful for the parents, because in the background of lack of occupational therapists, psychiatrists, lack of guidance, so experiences of the parents will be very useful, I feel. And we have to evolve the methods, rehabilitation methods, in the apply to the rural situations and Indian conditions. That is very important. And I too request and appeal national institutes to bring awareness in the students to join in the courses like occupational therapy, rehabilitation psychology, clinical psychology. Because people are crazy to MBBS or BTech or like that other courses. Occupational therapy is very much needed. Psychology is very much needed, even according to the new educational policy also. The psychology is very important for normal students and children with autism. So we have to promote these courses. We have to encourage the students to join in these courses. And I am well connected to occupational therapy courses in Nayak Hospital, Mumbai, Nirtar, and NIPMED. But the quantity of the occupational therapists and the quantity of the problem, when compared to that, the rehabilitation facilities is very less. Neurodevelopmental therapy, sensory integration therapy, all these things are common rehabilitation specialists don't know at all. And facilities also are there, infrastructure is also not there. We have to evolve something like that. So, and more important is what I feel is one important point: respect and love the children with autism. If you give the respect to the children, they will do a lot of miracles. I'm repeating this word by Dr. Srinivas. Dr. Srinivas is a reputed neurologist from Chennai, and he is father of autistic child. He has done a lot of work on autism. Being a father of autistic son, he led so many things from the son. And something what he says is, he is God to me, because he got so many intuitions. Usually autistic children, though there may be social or communication problems, because of their intuition, because of their intelligence, they are overtake normal people also. Like that. So what I feel is empathy, samvedana. Empathy is very important to create empathy in the society, in the parents, in the professionals, and in the doctors, everybody. So that is very important. And the simple thing, first you respect the autistic child, then he will respond, then we can rehabilitate him easily. So such type of innovative interventions, they should be, and interventions by, especially by the parents, they should be registered, they should be circulated, shared to all parents. That is important, I feel. So once again, I feel honored to participate in this webinar. I interfered in between the lectures. Lectures are very important, so I don't take much time. I'm once again thankful to Ram Kumar ji and Yogesh ji for giving me the opportunity. And I'm very much interested in autism. Saksham is working on autism in Trivandrum, Calicut, Mangalore, Bengaluru, Latur, in some areas. We have got our own projects, and we affiliated with the because few projects are affiliated with us. So we are working in autism. So in the future webinars, I request the organizers to have the topics like that, to share the best practices of the professionals and parents, and indigenous methods, evolve the indigenous methods which will be approachable and available to the common man of the India. That is very important, I think. And in the background of the deficiency in the occupational therapists and psychologists, we have to plan, we have to go ahead, and we have to encourage and motivate the young students to take this type of courses. By these words, I want to finish my speech. Saksham Bharat, Samartha Bharat. Namaskar.
Thank you, sir. We are extremely grateful to have you with us today. So now let us move to the next technical session. Our next speaker is Dr. Prathibha Karanth. Madam is the founder, director, and managing trustee of the Comdeal Trust, Bangalore. She worked as professor in NIMHANS, Bangalore, and Aish, Mysore. She had received the Lifetime Contribution Award from IRC Bangalore in 2016. She was also awarded with the Rita Peshwaria Oration Award in the year 2015 by NIEPID Secunderabad and Ministry of Social Justice and Empowerment. She received the Mahila Tilakam Award by the Department of Social Welfare, Government of Kerala. She was awarded the Professor R.K. Ojha Oration, Indian Speech and Hearing Association in 2011. She is a recipient of Vimla Virmani Award in the year 1987 by the National Academy of Medical Sciences, New Delhi, 1986. Madam was the president of Indian Speech and Hearing Association. She was a member of the EC and DC of NIPID. She is also the member of Scientific Advisory Committee, Sri Chitra Tirunal Institute of Neurological Sciences. Madam is a member of Scientific Advisory Committee, ICONS, Shoranur since 2017. She is a member of Advisory Board of CADREE Trivandrum since 2017. She is also the member of Task Force on Cognitive Sciences, Department of Science and Technology, Government of India from 2014 till 2016. She has had publication in over 15 books and manuals and over 80 research papers in ResearchGate. She had guided 7 PhD theses and 198 postgraduate theses submitted under various universities. I request all the participants to put your question for Madam in the chat box. We will take up the question after Madam's session. Ma'am, now it's over to you. I request you to take up the session, ma'am.
Thank you. Can you hear me?
Yes, ma'am, you are audible. Thank you, ma'am.
I think my screen share is taking a little while, but I can start. I'd like to begin by thanking the organizers of this webinar, Major Ram Kumar, Dr. Shilpa, Dr. Murugeshan, and the entire team from NIPMID for having invited me to participate in this webinar. It's a pleasure and an honor. I think the COVID pandemic has forced us all to go strong on webinars. So for us, it has been an unending series of webinars over the last couple of months. But this is a particular pleasure to be, sharing our work with all of you. It is taking quite some time to start. It did take a while to start the screen earlier too. What I will be talking about is the work that we have been doing for the last 20 years with children with autism spectrum disorders. And I would like to start with an overview of the changes that we have seen in this field over the last 20 to 30 years. Autism has moved from autism to autism spectrum disorders, which means that we acknowledge the wide variety of symptom clusters, behavioral patterns, difficulties in development that the children and the young adults also, as well as the older adults, in fact, face over a lifetime. The interpretation of the disorder, which in the 20th century was largely seen as a psychiatric or a behavioral disorder, has also changed considerably. And I think it's now reasonably well established that it is a neurodevelopmental disorder. Shilpa, do you want to use the screen from there? Because this is taking a long while. Dr. Shilpa? Hello?
Ma'am?
My screen is not sharing for some reason, so I would like to use the slides.
Okay, ma'am. We will share in a while. Ma'am, we will get back to that. You can start speaking. We will try to share the PowerPoint.
Okay, yeah. While these, massive changes have occurred, partly it's because also the numbers have increased considerably. Thought to be a very rare disorder way back in the 1950s, where we thought 1 in 10,000 children had autism. We are now talking about 1 in 60 or 70 children having autism. So, given the steep increase in numbers and the demand for understanding, for helping the children, the research, of course, has been intensive over the last 20 to 25 years. We are still nowhere near understanding what causes autism, but certainly the interpretation has changed from it being looked at as a psychiatric or a purely behavioral disorder to a disorder that has its origin in the biology of the individual, and more particularly as a neurodevelopmental disorder. Interestingly, while there has been the sweeping change in understanding the causation and the complexities of the autism spectrum disorders, the triad of symptoms that were described by people like Kanner way back in the 1950s, that triad still remains, which means what I'm trying to say is that the three major symptoms of autism that were recognized way back in the early part of the 20th century or midway through the 20th century, that there are behavioral issues, that communication is poor, and there is social affect. These three symptoms remain the core symptoms even today. So obviously we are describing the same individuals. Are you now able to see my screen?
Yes, ma'am. The PowerPoint is on, ma'am.
Okay.
We are in the third slide.
Okay, yeah. Can we go to the next one, please?
Ma'am, diagnosis.
Yeah. Can I go to the third one that I was talking about?
Ma'am, diagnosis DSM 1 to 5.
Yeah, but that's not on. Yeah, okay, yeah. What I just, described, the changes that, we have seen in the scientific study of autism spectrum disorders and the scientific understanding of autism spectrum disorders. But despite that, the symptoms that we still acknowledge and we look for have remained the same, and I explain the reason why they've remained the same. If you look at the diagnostic manuals and the most popular and recognized diagnostic tools that are used to identify autism, you will see that DSM-1, sorry, I think the screen has gone off again. In DSM-1, which was published in 1952, autism is described as a schizophrenic reaction, childhood type. DSM-5, the most recent version of 2013, which continues to be used today with some revisions and modifications. The symptoms are now described as those who have persistent deficits in social communication and social interaction across multiple contexts. And the second group of symptoms are that they have restricted repetitive patterns of behavior, interests, or activities. So you see how the change has come about. There are the different other versions of DSM 2, 3, and 4. I'm not going into it, but I just want to show you how our interpretation of autism has changed over the last 60 to 70 years. The severity of autism is based on social communication impairments and restricted repetitive patterns of behavior. But we're also looking at the broader issues that go with autism, not just the three core deficits. We're looking at the comorbid disorders. We know that they have a lot of sensory processing issues, though there is a lot of debate about this because quantifying them, measuring them, studying them within strict experimental paradigms is difficult because of their very nature. So there is a debate as to whether it is there or not. But those of us who have worked with young children and young adults with sensory processing issues have seen it and know that it is there. I'm sure science will find methods of measuring this and documenting this so that that too will become a part of the evidence-based literature that everybody looks for. A third interesting issue that has been more recently recognized in the last 20 years or so is that young children with autism who look absolutely fine in terms of their motor development can have disorders of motor functioning, which are known as the motor executive dysfunctions. These are very peculiar in nature because they are visible when the child has to convert an idea into a motor act. So on his own, voluntarily, or as a part of his daily routine, he may be doing something. But when you ask him to do a certain motor function, the child is unable to do it. And this too has been documented, measured, and written about. So the symptomatology has increased from the basic three of behavior, communication, and social deficits to include comorbid disorders, sensory processing issues, and motor executive dysfunctions. There is also a great emphasis on multidisciplinary approaches, particularly since we have identified a lot of the comorbid issues and the other difficulties that the children face. The theme for today's presentation is also that of the multidisciplinary team. And who are the members of this team? The physicians are there, of course, but it has moved from being solely the domain of child psychiatrists when it was considered a psychiatric disorder to include pediatricians, developmental neurologists, and psychologists. And who are the interventionists? Physio-occupational therapists, physio more recently, since we are now beginning to identify issues with muscle tone and posture and such like. Occupational therapists, because we know now that the children have a range of sensory processing issues. Speech language therapists, because we now believe that the communication deficit is not a behavioral disorder. It's not that the child does not want to communicate and therefore does not communicate, but because he has difficulties in communicating. And therefore, speech language therapists, psychologists, of course, in terms of the overall development and well-being of the child, educators, because given the numbers, these children are a part of the larger society and we have to accommodate. And of course, given, that our entire thinking about children with difficulties not being excluded from the mainstream society has become much more stronger in the last decade or two. So these are the multidisciplinary teams which work with the children as they grow and find their own feet in the world. There is also a lifelong approach. Autism doesn't vanish. We don't know the cause, so we don't have a cure. By helping the children very early and very intensively early in life, many of them have a good chance of being able to function in everyday society like all of us. Some may have severe difficulties and may not be able to stand on their own feet and live an independent life. And they may need more support across the lifespan. But even those who do well, because of the issues that are involved, they may need certain adjustments, they may need some support. So it is a lifelong approach, beginning with early intervention and then schooling, all the problems that crop up with adolescence, which all of us face, but it's much more so for a child with a disability, and of course early adulthood and joining the workforce. So it is a lifelong approach that we are looking at. I would like to illustrate, what can be done and how these children can be helped to find their rightful place in society by talking about our program, which is an early intervention program, because it illustrates the team approach, the multidisciplinary approach, and all of the many different aspects of support that these children need. Communication Deal, the program we started in the year 2000, focuses on early intervention. Why did we choose early intervention? Why did we focus on early intervention? It's because early intervention is it is scientifically documented to produce the best long-term benefits. As our chief guest for the day was talking about the acute shortage of therapists in this country, trained therapists, we do have an acute shortage of both intervention programs as well as therapists. And we don't have adequate facilities for sustained intervention, which is intensive and therefore needs a lot of people, trained people, a lot of time, and a lot of other facilities too. The costs involved. The current costs, if you have to avail of these services privately, are exorbitant. And unfortunately, unlike the Western countries, like United States or wherever, where insurance benefits are given and cover the therapy costs, in our country, insurance doesn't cover any of it. And of course, the steeply increasing number of children with autism spectrum disorders. Given all of these, this was true in the year 2000. I think it's marginally less so now, but only marginally. So we believe that the most economical way in which we could maximize the effect of our scant resources was to focus on early intervention because it has been documented to have a lifelong impact. What it basically means is that if you provide early intervention of a good quality, then a lot of the deficits or difficulties, whatever you want to call them, of the person with autism spectrum disorders can be managed, and he has the best chance to live on his own feet as an adult. So this is the reason why we focused on early intervention. What are the theoretical underpinnings? We do believe that it's a biological, neurological disorder rather than a psychiatric disorder. We do recognize the range of sensory perceptual disorders and the motor executive difficulties. We see the communication, social, and cognitive issues in autism spectrum disorders as consequences of the sensory perceptual and motor difficulties rather than as core symptoms. The behavior problems exhibited by the children, we interpret them as arising out of these difficulties rather than being an indispensable part of the disorder. Intervention, we think, should be multidisciplinary, profile-based, early, intensive, and within a developmental framework. I will illustrate how we do this as we go on. This is the manual that we published on the program some 10 years ago, after having worked on the program for nearly 10 years. The Communication Deal Developmental Checklist is the core instrument that we use to measure the child's difficulties and to help the team and the family support the child and guide him towards age-appropriate skills at the earliest possible time. These are available in English, Hindi, Kannada, and Bengali as of date. Who are the members of our multidisciplinary team? We began with occupational therapists, but as I said, as we worked, we have been learning from the children, and our program is entirely influenced by the ground learning, what we learn while working with the children rather than what comes from theory. So we did find a lot of children having issues with muscle tone, or floppy children, and of course this affects their overall well-being. So in the last 10 years, we've incorporated physiotherapists also, along with occupational therapists. We have speech-language therapists who work with the communication deficits. We have developmental psychologists who work with the overall development of the child, particularly the cognitive, emotional, and social aspects. And the educators and the psychologists work hand in hand. Along with this core intervention team, we have a broad network of physicians, which includes child psychiatrists, pediatricians, developmental neurologists, clinical psychologists, and geneticists. So this is how we do our assessment. In the little table that you have there, It reflects the multidisciplinary assessment that we do. There are ASD-specific issues that are measured. For instance, in the first column there, you will see what is termed as PLS. These are the prerequisite learning skills. If you read the literature on autism, everybody talks about how they have difficulty in making eye contact, in attention, in joint attention, how they do not comply to commands, how they are restless and either cannot sit in a place or don't move from a place from hours together. These are the prerequisite learning skills which literature talks about, but seldom are they measured in a child and seldom are they addressed in therapy. For us, this is a core beginning. And the color coding that you see is basically, if it's very severe, then we mark it as red. The yellow is in between, and the green is where it should be. So here is a very young child. This is the profile of a very young child who is about 28 months old, 2.4 years. And you see that as compared to what is appropriate for his age level, all of the prerequisite learning skills, except with I think some measurement that the speech therapist does in terms of oral structure movements. His jaw movements seem okay, but everything else is not on par with that of his chronological age. So we measure and we document this for each child. I'm sorry, I think I jumped some. Okay. At the same time, on the one hand, we look at the autism specific issues of the prerequisite learning skills, of the sensory processing issues, of the behavioral issues. But at the same time, we profile the child in terms of developmental skills that are expected of a child of his age. These have been studied, norms have been developed. So here again, of the same child, you see that in the first column, his gross motor skills are reasonably okay, a lot of green, but there are yellows and there is red close to his age level. In the second column, we are depicting the fine motor skills. The third one are his daily life skills. And you see none of these are on par with his age level. Then you have the receptive language or the understanding of language. And you see again, he is like functioning like less than a 1-year-old child. His expressive language is severely affected. That's the fifth column. His speech is not even like that of a 18-month-old child. Some inconsistent behavior before that. Cognitive skills, on the other hand, seem to be reasonably good and close to his age level. But then you go to social skills and you see once again, there is a big gap. The last is the emotional skills and the emotional well-being of the child. So here we are comparing the child with what is expected from a child of his age, a typically growing child, and where does this child stand? So these two become the core of our intervention program. Once we profile a child like this, then we start the intervention. And the multidisciplinary interventions, it is truly multidisciplinary because the team works with a group of 12 children. They are on the ground every day, 3 or 4 therapists with 12 children. We started the group intervention largely because in our individual practice, which most of us are trained in, we found that the children were improving one-on-one. But when the child picked up considerably and came close to his age level, and we suggested that the child now be enrolled in a regular school, unfortunately, the child would stick back and was unable to maintain the gains that he had made in therapy. And we realized that this was because he was comfortable within the situation where he's with a therapist or a parent and just him. But the moment you put him in a peer group, he is unable to hold his own. And that is why we started the group intervention. But I think it had a lot of incidental gains, the understanding, the cooperation, the respect that we have among our team members. It supported it enormously. We are all trained in our individual disciplines. We do play lip service to team approach and teams working together. One of the hardest things that I had to do is to get those teams to interact with each other. But when they were assigned to a group of 12 children and said, look, these are your 12 children, this is your responsibility. End of the academic year, 10 months later, show us what you've done with these children. They did, in fact, then work as a team. So a large group is assigned to a team of therapists. They have large group activities, they have small group activities, mid-level groups. They work together, often with the parents, on a day-to-day basis. The intensity varies. We have different kinds of programs. We started with a very intensive 3 hour per day, 5 days a week, 10-month program. And then we've moved on to develop other kinds of programs because the intensive program cannot be accessed by every parent who needs the help, particularly those who are not in urban centers where this kind of help can be provided to them. We do regular monitoring, frequent assessments, and family counseling. How do we do the intervention? What is the intervention? These are the intervention manuals. There are about a dozen of them. This is basically a compilation of lesson plans, which all of you are familiar with, beginning from the birth level up to the age of 6 years. We took our upper level as 6 years because that is the age level at which school admission is kind of closed. So if they don't make it at that time, then mainstreaming these children becomes very difficult. So all of these consist of a range of very simply written lesson plans which have been tried, tested, and only then documented. So what it consists of, is stepwise, how do you build on these skills? There are, this is from the language manual. You find that there are activities that address receptive skills. There are activities which address expressive skills. Our goal is that the child should become age appropriate as early as possible. The materials are from middle class. We looked at materials which were culture friendly. They are materials that are available to an average middle class family. We give multiple ideas for the same skill or goal. And there is a visual illustration showing how this activity is to be done. This program was then, subsequently, I think in 2017, it was published in the United States also and is being used there too. So this is the international edition that was published by Plural Publishers in 2017. Along with that, let me just, I think I skipped a slide. This is a very important slide. I showed you the profile of a child in terms of the autism specific issues, which is the top half of the screen, the extreme left, and I showed you his developmental profile, which is the lower half of the screen. This was when the child joined the program in the month of June 2013, I think. He was 2 years and 4 months old. I told you how we work towards increasing these skills starting at the baseline. This is halfway through the program. And you see that the team addresses the autism specific issues. A lot of them are changing. We don't have a whole lot of red there. There is a considerable amount of yellow, but the greens are appearing to come, which means that they are getting to be age appropriate. Similarly, the developmental skills are also building up. And the third column that you see is at the end of the year, which is end of April, when the child is 10 months older. And of course, the bar is increased to his chronological age. And you find that the child, both in terms of the autism specific issues, as well as his developmental skills, and this is important, both of them have moved on and are now close to his age level. A child like this, we would send on to a mainstream school and provide him with some additional support in individual therapy to stabilize the newly acquired skills. This is the best chance that we have when a child comes to us as young as this, because then the changes come about much more rapidly. In our manuals, we have illustrated what happens with children of different ages when they come older to us, 4.5, 5, 6, which is quite common in India. Then it takes much longer and it's much harder work. So this is the way in which we provide early intervention and get the child to be comfortable, both in terms of reducing the autism-specific issues and enhancing the developmental skills. So it's a two-pronged approach, and both of these are important. Unfortunately, most of the time, we do not look at the developmental skills of the child. We only address the autism-specific issues. But we must remember that because of the autism-specific issues, this child loses out on acquiring developmental skills like his peers. And he needs support in those two if he is to hold his own among peers in a mainstream school. I did mention that we learn from the children. Apart from our manuals, over the last 10, 15 years at least, we have developed a lot of other training material completely based on the problems that we find while we work with the children in the clinic. It could be something as basic as toilet training, feeding, to something which is of a much more complex level like social skills, social communication. So these were difficulties identified in the clinic. We kind of try to address them, test methods. Only when it works do we document it as a communicate. We have just completed a series of webinars on our communicates this last month, and they will be available on our website. So anybody who's interested in this can go and look at it and listen to them, which explains all of these. These are just some examples I've given: oromotor and sensory kit, pragmatic kit, proto-vocabulary kit, visual kits, gesture manual, independent activity manual, toileting. So these are some of the things that we have developed over the years. We've also done some evidence-based studies. If one is to be accepted, in the current scientific world, you have to build up the evidence for what you're doing. We do have a considerable amount of data. We now have over 20 centers across the country, and we are looking at the data from all of these centers. This was an early study which was published in the Indian Journal of Pediatrics, where we studied a group of children across a period of 8 months in terms of their developmental skills, as well as the behavioral issues, which was measured by an independent investigator using CARS. At the end of 8 months, we found an average gain of 17.4 months across in terms of developmental skills across these children, while there was a significant reduction in the behavioral issues. Please note that we do not address behavioral issues specifically unless it is unmanageable and interferes with the child's functioning in the group. So while you help their issues, while you help their developmental skills, the behavioral issues start coming down. We also did a long-term study. This is the children who had enrolled in our clinic from 2001 to 2010 were studied over a period of time by following up with the families, basically. And we found that at the end of 2010, 76.4% of the children who had completed our program continued to be in mainstream schools 1 to 9 years after having completed the program. We also have to look at it from the point of view of what is reality in India today, where our school systems are highly competitive, hardly provide any additional support for children with autism spectrum disorders. Despite that, thanks to the early intervention, thanks to the parental learning and the parental support across the school years, 76% of the children continue to be in mainstream schools. It's my pleasure today when I get calls from across the country or even outside, parents telling me my child is now in engineering college, my child is now in university. We had one of our youngsters complete his graduation in philosophy from the London School of Economics. So this is the long-term outcome when you start early intervention and provide it in a cohesive manner. We are aware that such multidisciplinary support has to be provided across the lifespan. We had hoped that we would be involved in providing it during the school years, but unfortunately, the demand for the early intervention program grew so much that we are still grappling with it. We have started some early school programs like the social communication program, which are still in the trial phase, but we do acknowledge and recognize that these youngsters do need a lot of support across the lifespan, and hopefully will be able to address those issues also in a similar manner. So this is our head office in Bangalore. As I mentioned, we have 20 plus centers across the country. If you want any further details about what we do, how we do, you can contact us at the Comdeal Trust. I've given you the email ID as well as our website address. If you are interested in the materials, the manuals, then you can contact us at resources@communicates.com. For our publications, please look at academia.edu. I hope I have done justice to the invitation from NIPIT. I've enjoyed putting this together and sharing it with you, and I hope that you in turn will be interested in taking this up further, not only just in terms of early intervention, which is crucial. As your director mentioned, the focus is entirely moving to younger and younger children, early identification, early intervention. So we are also now trying to pick up children younger than 2 and start providing parent-mediated intervention. Thank you.
Thank you, ma'am. Thank you very much for your illuminating and informative presentation. It was very enriching and enlightening too. We will be taking up with the question and answer at the end of the session, at the end of the program. 2 speakers are also there, so we will take up at the end. Thank you, ma'am.
Okay.
We have a poll question for our participants. Participants, there are a poll question. Please answer the question. Thank you, participants. Our next speaker is Mr. Mukesh, T. Mukesh, a faculty of NIPIT. He has done his post-graduation in occupational therapy with specialization in neuroscience from National Medical College, Mumbai University, and has a post-qualification in psychology from Madras University. He is currently pursuing as a doctoral scholar in the field of rehabilitation science, working in the area of autism. He has over 20 years of clinical academic experiences in the field of pediatric rehabilitation. He is trained and certified in certification in special learning disability, certification in sensory integration, Wechsler intelligence scale for children, certification in cognitive behavior therapy. He has been actively involved in research activities and had presented papers in various national and international conferences. Recently, he had presented a paper on sensory processing issues in autism in the BMI International Conference 2020 in Hyderabad. Mr. Mukesh has also been a resource person for numerous capacity building programs at national and international level. He had also authored many course books for IGNOU, NSOU, and the Madras University. He is a life member of All India Occupational Therapy Association. Presently, Mr. T. Mukesh is heading the NIPIT Regional Center, Kolkata. Over to you, sir.
Once again, very good evening to everyone. During this current session, I'll be presenting on understanding of sensory processing in autistic children. My counterpart, Mr. Mohan Gopal, he will be presenting on the assessment and intervention aspect of sensory integration. My presentation, I'll be covering on autism and sensory processing. What are the basic senses and special senses involved in that? And what is sensory processing disorder and what sort of impact it has on children with autism. And I'll be touching upon the recent research on sensory processing and autism, which will be acting as a guiding principle for the future assessment and intervention. Every day, we all are bombarded with millions of sensory stimuli every other second. Some we are aware and some we are not. Some we deliberately ignore and some we filter it out to focus on the relevant stimuli in a given situation. The process of receiving, interpreting, and responding to these sensory stimuli becomes very essential in producing adaptive and acceptable behaviors in our day-to-day lives. This sensory processing and integration, which happens with most of us in a more automatic and stress-free manner, at times becomes very hard and stressful for a group of children and adults. Autism spectrum disorder. As we all know, autism spectrum disorder is a neurodevelopmental disorder, clinically characterized by impairments in social interaction, communication, restricted and repetitive behavioral patterns, interests, and activities. Among those diagnosed with ASD, it is estimated that over 90% show symptoms of sensory abnormalities. The diagnostic manual for mental disorders, DSM-5, hypo and hypersensitivity has been included as a diagnostic criteria for ASD. Atypical sensory processing are a ubiquitous feature of autism spectrum. Genius, the pioneer in the field, and spent her career conducting research and developing theory and intervention strategies. Based on her research and clinical experiences, she has published work describing the difficulties in processing and integrating senses that occurred in children with LD and autism. Jane Miller, PhD, OTR, who studied under GNAS, had furthered the work through her research on sensory processing, education, and treatment. Sensory processing, it's a neurological process that enables us to make senses of our world by receiving, registering, modulating, organizing, and interpreting information that comes to our brains from our senses. It is a complicated work our brain performs to make sense of the gazillion bits of information that comes flooding in every second from our environment. This processing helps us to receive the sensory messages and turn them into appropriate motor and behavioral responses. This sensory processing is responsible for autonomic functioning such as heart rate, digestion, respiratory rate, salivation, perspiration, pupillary dilation, urination, sexual arousal, breathing, and swallowing. And it is also responsible for higher level cognitive functions such as attention, concentration, perception, emotions, memory, coordination, and arousal levels. This sensory processing involves 8 sensory systems. 5 are the basic senses and 3 special senses. 5 basic senses, as we all know: auditory, visual, gustative, which is otherwise taste, olfactory, which is otherwise smell, and touch or tactile. It's basically of a discriminative touch. And when you go to the special senses, we have three special senses: vestibular, proprioception, and interoception. The vestibular receptors are present in the inner ear and develop during the preschool years. Maturation of this sense normally gets completed until age 10, and this sensation impacts our reaction to gravity, movement, and balance. And this sensation is very much essential for gross motor development, bilateral coordination, head and neck control, muscle tone, as well as our arousal levels. Proprioception, the joint position sense. This is the system which tells the brain when and how the muscles are contracting or stretching, when and how the joints are bending, extending, or being pulled or compressed. This defines the body's position in space, determines how we interact with the environment, and determines how much force we use while performing activities. Finally, interoception, the eighth sense. This is defined as a sense of internal state of the body. The interoceptive signals are projected to the brain via a diversity of neural pathways that allow for the sensory processing and prediction of internal body states. This sensation enables us to experience essential feelings such as hunger, fullness, thirst, itching and pain, body temperature, physical exertion, as well as emotions. Pyramid of learning. This is a model proposed by William and Schellberger. This model proposes that learning is incremental and the child's sensory integration plays a huge part in development of the learning. It outlines the foundational skills at the bottom of the pyramid and the skills that are supported by the foundational skills on the tiers above. Once the bottom tiers of the pyramid are adequate, the tiers above can be more efficiently developed. As you all can see, the very bottom box in the illustration is the central nervous system, which most closely supports the second tier. The second tier identifies the children's sensory systems. The third tier depicts their sensory motor development, that is body scheme through body awareness, reflex maturity, that is having developed reflexes for safety purposes, ability to screen input, that is knowing what sensory experiences are important to pay more attention to, postural security, confidence in maintaining certain postures to prevent falling, awareness of both the sides of the body, that is bilateral integration, and motor planning, that is the ability to plan the movement. The fourth tier depicts perceptual motor development, which includes auditory language skills, visuospatial perception, that is identifying what is seen in space, attention center functions, which is maintaining attention to tasks, eye-hand coordination, oculomotor control, that is locating and fixating on something in their environment, and finally postural adjustment. The fifth tier, which is the topmost layer, that depicts intellect, academic learning, and daily living activities, as well as behavior. This pyramid of learning basically gives us an idea of how important the sensory systems play a role in various stages of a person's life. A good sensory processing enables all the impulses to flow easily and reach their destination quickly. Sensory integrative dysfunctions emerges when some sort of a traffic jam happens in the brain. Some bits of the information get tied up in the traffic, and certain parts of the brain do not get the sensory information they need to do their jobs. That's when the question of sensory processing disorders arise. And by definition, given by Miller in the year 2013, sensory processing disorder is a neurophysiological condition in which sensory input, either from the environment or from one's own body, is poorly detected, modulated, or interpreted, to which atypical response are observed. Sensory integrative dysfunction, or SPD, originally termed as sensory integration dysfunction, New terminology adopted is SPD, sensory processing disorder. It's basically identified by Mr. Gene A.S. And as we discussed earlier, these SPDs influence behavior, they impede learning, they impact movement and coordination, they interfere with relationship and socials, and it affects, in fact, children in all settings. 5 to 15% of the general population are affected. Approximately in 8 to 10 in the 8 in 10 in the autistic population are affected. SPD in the medical community, it is not recognized as a formal medical diagnosis. Came close in ICD-10 formulation. Sensory differences are included in DSM-5, diagnostic criteria for autism. It's included in the diagnostic manual for infancy and early childhood. Indicators of SPD. Indicators of SPD include inappropriate or problematic motor, behavioral, attentional, or adaptive responses following or anticipating sensory information. Sensory processing disorder, according to Miller, it has been classified into 3 areas: sensory modulation disorder, SMDs, sensory based motor disorder, and sensory discrimination disorders. Sensory modulation disorder are again subdivided into 3 types, and sensory based motor disorder are having 2 phenotypes, and sensory discrimination disorder will be cutting across all the sensations. So, sensory modulation is an ability to organize the degree, intensity, and nature of responses to sensory input in a graded and adaptive manner. The various phenotypes of sensory modulation disorder include sensory over-responsivity, sensory under-responsivity, and sensory craving. Sensory over-responsive children are hypersensitive to sensations. Their behaviors include responding too much, too frequently, or too long to sensory stimuli, getting aggressive or impulsive when overwhelmed by sensory stimuli, being irritable, fussy, and moody, that are called as hyperalert emotions, unsociable, avoidance of group activities, difficulty forming relationship because of the reason that social scene itself becomes too overwhelming, and they are excessively cautious and afraid to try new things and upset by transition and expected changes. Sensory under-responsive children are less sensitive and less aware to sensory stimuli than most people. The sensory under-responsive behaviors normally include high pain threshold, does not notice when touched, unaware of need to go to the bathrooms also, preference for sedentary activities, being passive, quiet and withdrawn, difficulty to engage in social interaction, and excessively slow to respond to directions, and lack of motivation and drive. There's another category, that is the third category of sensory modulation disorder, that is sensory craving. Children with sensory craving, they seem to need much more sensory stimuli than most people. Sensory craving behaviors include being constantly on the move, liking crashing, jumping, roughhousing kind of stuff, excessive spinning, swinging and rocking. And these people constantly involved in touching objects or people, seeking vibration, watching spinning objects, constant talking, and trouble turn taking in conversations. And the next major type under is sensory processing disorder is sensory discriminative disorder. Sensory discrimination refers to how qualities of sensory stimuli are perceived, meaning were attributed to them. Children with sensory discriminative disorders exhibit problems in discerning the characteristics of sensory stimuli. For example, children can perceive the stimuli and can modulate their responses, but cannot tell precisely what or where the stimulus is. This may take extra time to process, thus making them appear to be slow, and this often co-occurs with developmental coordination disorder and dyspraxia. The third major category, that is sensory-based motor disorder, it basically has got two phenotypes. One is postural disorder, another one is dyspraxia. This SPMD is actually defined as a motor challenge with an underlying sensory basis, and it has got two subtypes. As I already told, it's a postural disorder and dyspraxia. Unlike sensory modulation disorder, in which individuals have difficulty regulating sensory input, here the children with SBMD are regulated, but they have a sensory motor challenge. In fact, SMD and SBMD can occur separately, or they can co-occur also. Variability within SPD. Sensory differences can impact any individual sensory system or multiple systems, and individuals can have mixed responses also. Across the system, they may under-respond to touch input, but over-respond to auditory input. And within the same sensory systems, at times they may be over-responsive to light touch, and they may be a cravers of deep touch too. Recent research there was studies conducted by Kleinens et al. And Tottenham 2014 have found that in individuals with ASD, that the amygdala overactivates with eye gaze compared to typical controls, and that in these individuals, amygdala activation is correlated to time spent on gazing, that is looking at eyes. Further, hyperactivation in the amygdala to eye contact may indicate a modulation dysfunction ASD, in which some have proposed an indication for why individuals with ASD avoid eye contact with others. There's another study which was taken up in the year 2013. The study was conducted by Shivani et al. They reported that children affected with SPD have quantifiable difference in the brain structure. For the first time, shows a biological basis that sets it apart from other neurodevelopmental disorders. Then another research which was taken in the year 2014, the research was conducted by Chang et al. They reported that children with SPD have decreased structural brain connection in specific sensory areas different than those in autism. There is another few studies which are taken up in the year 2016. They demonstrated that insula is an important emotional related region. It was not actually identified by Jean Ayers in her original research. This particular area is involved in the registration deficits, sensory registration deficits, what we commonly see in children with ASD. This insula is important for attention, and it is a core mode of salience network, which responds to novel and relevant sensory stimuli and is important for cognitive control and switching between default mode networks to task-based networks. The insula also acts as an integration center. Sorry, I missed a slide. Also acts as an integration center for physiological and emotional perception. This cortical region has been reportedly to be altered in autism spectrum disorders. Insula abnormalities have been observed in individuals with ASD while performing various cognitive tasks such as social processing, emotional processing, spatial attention, set shifting tasks, and executive function tasks. Jean Ayers had suggested that a collective set of brain regions associated with emotions, often called as limbic system, is responsible in part for sensory registration. She posited that these regions of brain are atypical in children with ASD, and therefore these children do not register and value stimuli in the same way as typically developing children do. She had also proposed that Sorry, I'm missing a. Which slide I am in now? I'm in 20. He has also proposed that the more poorly this part of the brain is working, the less the autistic child will be responding to the therapy. The research which has been taken up in the year 2019, it says like many aspects of AS hypothesis about the nature of the disorder were found to be highly consistent with the current literature on sensory processing in children with ASD. But there are some discrepancies across various methodological techniques and ASD development. With additional characterization, neurophysiological profiles of sensory processing in ASD may serve as a valuable biomarker for diagnosis and monitoring of therapeutic interventions such as sensory integration therapy. The very latest research, which happened in the year 2020, this research reports that children with SPD and ASD, they significantly differed from the typically developed group with greater sensory processing challenges. And this study, in fact, tried to compare the two clinical groups, that is sensory processing disorder and ASD. And it is reported that ASD had significantly greater control and sustained attention deficits and less sensory issues than children who had SPD alone. These different profiles may provide guidance in identifying appropriate individualized therapeutic strategies for these children. In fact, these recent research findings, it was actually very much in support of the work which was done by Genius in the year 1970s. Though those days there was no neuroimaging kind of a support was available. And as I mentioned in the beginning, there are areas where some discrepancy also is being found. All said and done, these findings will be contributing in a greater way in planning assessments and intervention for the intervention in the area of sensory integration, either it is for the ASD group or you call SPD. So all these children planning the assessment intervention, these findings will be of very much useful. I'm just thank you very much. Thank you.
Thank you, sir, for your evidence-based presentation. For the participants, we have a poll question. I request all participants to put your question in the chat box. We will take up the questions at the end of the session. Our last speaker for this international webinar is Mr. Mohan Gopal from Ireland. Mr. Mohan Gopal had qualified in occupational therapy from TN Dr. MGR Medical University, Chennai, India. He has 22 years of experience working worldwide, including countries of India, Canada, West Indies, and Ireland as a clinical occupational therapist for children with special needs. Mr. Mohan is passionate in working with infants, children, adolescents, adult, and elderly population with physical, sensory, and intellectual disabilities, and has extensive experience in using sensory motor strategies for children with sensory processing difficulties. Mr. Mohan is registered with KORU, member of Association of Occupational Therapists in Ireland, life member of Association of Occupational Therapists in India, and Sensory Integration Network, and also registered with Ontario Society of Occupational Therapists in Canada. Nice to have you, sir, with us. Over to you. Over to you, sir.
Thank you very much for everybody. Can you all hear me?
Yes, sir, we can.
Yeah. So thank you very much for a brief introduction about me. This is about me. I have a 20 years of experience working in all parts of the country around the world. And I'm certified in sensory integration and praxis test with University of Southern California. I'm advanced level practitioner in therapeutic listening from Vital Links. I'm also practiced with transdisciplinary play-based assessment that is called TDPBA from University of Denver, Colorado, under the guidance of Ms. Tony Linder. I'm also certified in handwriting without tears in Canada. I have completed my advanced level training in Early Start Denver model, which is a gold standard therapy intervention for children with autism. I'm also certified in oral placement therapy for children with feeding and drooling difficulties and to enhance production of sound and speech clarity. This is about me. As Mr. Mukesh has explained about the sensory processing difficulties, I will be delivering a small brief talk about the assessment process and the intervention strategies which we use in the West and also a part of India where like some of these assessments are being carried out. So before I start, I would like to mention a few famous quotes which I'm more impressed about. We need the assessment process a mandatory approach for children with autism, which implies one of these quotes. One accurate measurement is worth 1,000 expert opinions by Grace Murray Hopper. She is the Harvard topper and it's one of our major computer scientists in States. She says that like one accurate measurement is worth 1,000 expert opinions rather being repeating the same thing again and again. The other person, Mr. James Harrington, has said that measurement is the first step that leads to control and eventually to improvement. If you can't measure something, you can't understand it. If you can't understand it, you can't control it. If you can't control it, you can't improve it. That's where like we all believe in today's like and for the intervention strategies. For the children with autism, that's what I do believe. We need to identify the areas which the children are lacking or difficulty in focusing on, which we need to use the measurements or using the assessment protocols. So if you use the appropriate assessment protocols, definitely you might end up understanding it properly and you can control it properly and you can improve it properly. So just go on to the assessment process. So in the West or in Ireland and Western countries, like these are some of the very famous assessment tools or the recent assessment tools which we use to identify the children with autism in terms of sensory processing disorders. The first one is the DASH or the Developmental Assessment for Individuals with Severe Disabilities or the Sensory Profile 2. People might be aware of the Sensory Profile, which is the older version. It's a newer version called the Sensory Profile 2. And the sensory processing measure and for the preschool, and the sensory integration praxis test, which is developed by Jean Aries, as Mukesh has explained. She is the pioneer in the process of the sensory integration therapy and intervention, and she developed this test for exclusively, and it is called the gold standard assessment for sensory integration. And for more the last, I would like to explain about a small, like the new assessment process called Early Start Denver model. It is a kind of a behavioral pattern model, but still like I'm literally like blown away using that Early Start Denver model, and like it's one of my best approach and assessment tool, which I use it here, and it's really working very well. So we're going into the assessments, like I'll be explaining you about all these assessments in detail. Dash, like it's appropriate for people with mild, moderate, severe, or multiple disabling conditions. It measures specific skill levels in children and adults from 6 months to the adulthood who have physical, intellectual, or sensory disabilities, including autism spectrum disorders. It uses like 5 scales, like which is mainly measured for using like sensory motor scale, which is like reflexes, gross motor, senses, and hand skills, and uses the language scale, which is like a non-symbolic communications, expressive language, and receptive language, and uses the social measures, awareness, which understanding of the self and others, including the social skills, and also activities of daily living skills, which matters a lot for children's how well independent they are in their own age level, on including the academic skills, like where like pre-academic skills, which is very important for them. So this is about the dash. Like I don't know, I'm not sure like how many people are using these ones, but this is mainly for children with like all type of disabilities, which I use it in my clinical practice, and it's one of the best assessment tool I recommend to all the therapists or even for any professionals who will be dealing with autism spectrum disorder. The next one, which I'm going to talk about, is the sensory profile. We might be aware of the sensory profile, the previous version, but like this is one, the sensory profile 2 is the latest version, which evaluates child's sensory processing patterns in the context of home, school, and these activities, starting from 0 until the 14 years and 11 months. That's what like some of the previous presenters and speakers was talking about. Like we can even diagnose the children's like born under 6 months of age. So this is one of the major tools which we use even from the birth or like from the first month, like how we can really understand. So it has classified into 4 major areas. It is called the infant sensory profile from birth to 6 months. Toddler sensory profile 2, it starts from 7 months to 36 months. The child's sensory profile 2, which assesses children from 3 years to 14 year 11 months. And the social companion sensory profile 2, which measures from 3 years to 14 years and 11 months. It's easy, very easy to complete. The completion time is only like 5 to 20 minutes, but like it's only a paper and pencil for our online administration. So I highly recommend some of these assessment tools could be like probably used in India to identify children with sensory processing disorder. The next one is the sensory processing measure, and the SPMP is called preschool. SPM is very comprehensive, clinically rich, and psychometrically sound for assessing children with autism. It's a seamless assessment from preschool through the age of 12 years. It assesses 2 major areas, that is the praxis and the social participation, and 5 sensory systems, the visual, auditory, tactile, proprioceptive, and vestibular functioning. Having said all these things, the SPM consists of 3 forms: the home form, which is completed by the parents; the main school classroom form, which is completed by the school; and school and environmental form could be completed with the therapist. It assesses main 8 areas of social participation: vision, hearing, touch, body awareness, balance and motion, planning and ideas, practice, and total sensory system. This consists of the SPM. The SPMP, which is the preschool area, which assess the children from 2 to 5 years, reveals specific problems including under and over responsiveness, sensory seeking behavior, and perceptual problems. I do use these sensory processing measure for preschool a lot in my clinical practice, and it really has been a valid tool in terms of like outcome measures and as well as. The next one I'm going to talk about is the sensory integration praxis test. As the previous presenter, Mr. Mukesh, has explained, sensory integration was theory developed by Jean Ayres in 1975 and above. She was the pioneer in sensory integration, and she has developed this kind of a tool, which is still a gold standard tool for assessing the sensory integration. It really measures the sensory integration process that underlie the learning and behavior issues. It helps pinpoint specific organic problems associated with learning disabilities, emotional disorders, and minimal brain dysfunction. It is applicable for children from 4 years to 8 years, 11 months. That's the only deficit which I feel like I can use it only for the children from 4 years until to the age of 8 years and 11 months. There are 17 subtests provides comprehensive assessment for space, visualization, figure ground perception, standing and walking balance, design copying, postural praxis, bilateral motor coordination, praxis and verbal command, constructional praxis, post-rotary nystagmus, motor accuracy, sequential praxis, oral praxis, manual form perception, kinesthesia, finger identification, graphesthesia, and localization of tactile stimuli. I never seen such an amazing tool which can really command all these major functional areas of praxis and the learning behavior. So this is one of the gold standard tool which we use it with children with autism who are higher functioning or are having a specific difficulties known about these specific areas. The next one which I'm going to use is like ESDM. It's called the Early Start Denver model. I'm a big fan of Early Start Denver model, as Madam Prathibha Madam was talking about the same kind of structure in her center. Like it is an evidence-based assessment tool used to assess all critical early learning domains and inform intervention planning for children diagnosed with autism. And it is also like refined only from 12 months to the 46 months. But again, having said that, it gives us the basis of understanding of normal total learning and development. It focuses on building positive relationship. Teaching occurs during natural play and everyday activities and uses play to encourage interaction and communication. So it mostly all the intervention patterns are being developed using play. So play is a major occupation for children with anybody. So for autism, most of the time like they're more self-centered, they're not able to play much. So using this kind of an approach is one of the best approach I used forever, and gives a very good outcome measures as well. Intervention is provided in the home by trained occupational therapists. So you need to get certified for implementing or assessing ESDM, and you can train parents where you can really mark the 4 levels, which is I mentioned the right now focus corner. Like the assessment patterns, it is a more evidential pattern where we can see the parents working on all the skills. Because most of the people come to therapy once in a week or twice in a week here in Ireland, but on home as well in India. However, like we need to impart some kind of a knowledge to the parents so that like the parents can also know what we are working about, and also to work about like what are the next stage the child can proceed about. So this is one of the best tool ever I can really recommend to any therapist or any kind of a professional like working at everybody. I also like suggest like some people can say ask me like who all can do all these things. The ESTM training program was developed by UC Davis Mind Institute in Sacramento, California. ESTM therapist may be any one of the following, like could be a psychologist, could be a behavior therapist, could be an occupational therapist, could be a speech and language therapist, pathologist, or early interventionist, or even like a social worker. So once they get certified, they can really practice these one, and it's one of the best things. The intervention focus on boosting children's social, emotional, cognitive, and language abilities, and it also really works on the early learning domains of imitation, communication, social, cognitive, motor skills, adaptive behavior, and play. These are the main major areas which the children with autism or deficit in when they have been diagnosed. So I use this one every day, and I feel like very much confident in using this one for most of the kids, and the outcomes are amazing, to be honest. And like I really recommend like for the people to have a look into this one. And if you need any more details about this, please contact me. I can give you more details about this. Having said all these about assessments, like we are going to plan for the intervention. Once we complete appropriate assessment protocol, we can have appropriate level of achievements or level of function level of the child where they are at. Then only we can plan for the intervention pattern. So once we know about the intervention, then it's easy to go ahead. So what are the intervention strategies and approach as an occupational therapist or therapist we use for children with autism? The first and foremost is the sensory integrative approach. The second is something called as planned sensory activities or the sensory diet program, which we have to implement during the course of the day. And the visual schedule are the structured routines where the child's need to anticipate what is going to happen next. So once they are able to anticipate what is going to happen next, they are very well able to really get into the routine. And appropriate assistive devices really help them to focus on their own sensory processing difficulties, which may hinder them during the course of the day. And also, like we in Western countries, we use loads of multi-sensory room experiences to really calm the children down when they're having like higher level of activity level. And also, main and foremost, I will say like the environmental adaptation, which is the main thing which we need to focus on for children with autism. So most of the time, it's the perceptual thing about the parents, how the child is not actively happening in a proper environmental setup. So we need to environmentally adapt so that like the children can be calmed down or like getting into more kind of a structure routine. So I'll be explaining in detail about each and everything. First, I go into the sensory regulation. So as Mukesh was explaining, the sensory or the self-regulation is within ourselves. Like it is the ability to manage your emotions and behavior in accordance with the demands of the situation, or ability to regulate activity levels to stay in a calm and alert state. So if you look into the three major pictures here, there's something called as a small cup, the right size cup, and the large cup. So what do you mean by self-regulation in terms of right size cup? It is called the typical sensory processing. They automatically fill and empty their cup efficiently. Interaction and environment is appropriate. For example, to say that like for any time if you see any child is putting their hands over ears all the time, they are not having a right size cup. They are having a small cup, like takes very little sensory input. The child may be over responsive to the input or sensitive and avoid to cope with the challenge. Exactly the same thing I said earlier. The child may be over responsive to the sound, that's why they're putting hands over ears. Or the large cup respond very slowly to input, needs more seekers or bystander to sensory input. Now we can see the small cup, the person who cannot take much sensory input. The right size cup can take in and empty easily, or the large cup who needs more input, which are something called as like always need more and more and more. I can say a good example for this, or these some children are always very active. They keep on moving. They're always on the go. It's very hard for them to sit them in the chair and focus on a particular activity. They always look everywhere, or they just bang the toys to get more input. They always put something in their mouth all the time. So these are the people are something called as large cut people. They need more sensory input really to regulate themselves. Having said all these things, there is something called as mixed cup or mixed profile, in which either under or over responsive or fluctuating depends upon the situation. So these people are also I see during my practice every day. So some of these kids are very fluctuating. One day they will be like seeking loads of movement. The next day they will be not seeking the movement. Instead they'll be avoiding some certain touch or some avoidance of certain sounds. So this is kind of a mixed cup. So these are the main things which we need to know about our child. Either they are a right size cup or a small cup or a large cup, where they all the senses which Mukesh has explained previously will fit into. All these normal senses and the special senses will fit into. Having said all these things, I really want to explain one more thing. When Mukesh sir was explaining about the pyramid of learning, the base of the pyramid is something called as tactile, proprioception, and the vestibular, are the touch, movement, and pressure. So those are the major basic senses in our body which we need to regulate, or how much we need to really understand the environment based us on those three senses. So if those three senses are not working cohesively within the body of the child, they will have a huge reflection about all these things about the self-regulation. So that's why I really wanted to emphasize more about the pyramid. So how the sensory integrative approach work well? The sensory integrative approach provides children with appropriate sensory stimulus in terms of tactile, visual, auditory, movement, and joint sense to improve the following. So most of the time, like parents will ask me like, what is joint position sense or what is like pressure sense? I don't know. I don't understand that. Like, then I'll give a small example. Like, if I give you a cup of water in a plastic and in a glass, would you hold that in the same pressure? No. So as soon as you touch the plastic, as soon as you touch the glass, your brain sends two different impulses to hold the plastic cup in a very light pressure or to hold the glass in a very firm pressure. So even holding two different types at the same time, you're exerting two different pressures. So this is called the pressure sense in our body. So that's why some of the children are huge difficulty exhibiting appropriate pressure for even a basic thing. For example, to say that you want to hold a toothbrush and you want to squeeze a toothpaste on the toothbrush, they are not able to do that. So what they do is like they'll squeeze everything off. Even to pour a cup of water in a glass, they usually like pour it everything up. Or even to button a small shirt or like a shirt, they are not able to do that. That's why they lack a lot of self-independent daily living skills, which in turn focuses on their touch pressure and all these areas. So the sensory integrative approach really helps them to provide sensory stimulus based on these sensory inputs, which is based on their level of the small cup or the big cup to provide appropriately. It improves the sitting tolerance, attention, and concentration, and reduce distraction. It improves touch tolerance. It provides enjoyable and relaxed environment. It improves the social interaction skill, which is one of the major areas manifested in children with autism. It improves body awareness and hand function skills. So when you say about body awareness, if I throw a stone at you, like what you do, like automatically in a split second, you might think, oh my God, that's a stone. I'll try to move it or I'll try to block. But again, imagine our children with autism, they just simply stand there. So improve about your own body awareness and what is the incoming stimulus towards your body they are not well aware of. So this one of the sensory integrative approach really helps them to understand about their own body and about the environment. It also improves their hand function skill, which is a major area for them to really to learn better through play. It provides appropriate behavior. I've seen like many children like always keep putting things in mouth or like eating every type of like it's called pica. They eat everything. So some of these children are like more like some we call as like picky eaters or like totally avoid certain tastes and foods and everything, or some children always like put more in the same like Mukesh Asar has said like hypo or hypo. They seek more input or like completely avoid. So the sensory integrative approach will give them more good of an approach which really help them to understand their own body and with the environmental group. Also, the last but not the least, improve the planning and organization skills. Like it's one of the major things for any children with autism or like you need typically developing child to understand to plan and organize what is we're going to do next. So it is one of the major things which I really emphasize. Then I'm going to go into next one. Sensory diet or the planned sensory program. So occupational therapists, we work on the sensory diet. It feed or nourish a child's nervous system. When a child's nervous system feels properly organized, it is better able to achieve optimum attention to tasks and performance of activities. For children with autism, that's what is happening is their sensory systems are not being fed or nourished. That's why they either seek more or even avoid more. So that's what like if their sensory systems are being properly nourished or fed, they're well able to achieve this or physiotherapists to suit individual needs. To highlight that, it is a dynamic document and changes according to the need of the child. As I said earlier, some children might be like kind of a mix up where some days they could be like more active, some days they could be very, very laid back. So it's a kind of a dynamic document based on the children's needs. We need to really highlight what are the things needed for the day, and we have to choose appropriately based on the child need. That's why the sensory diet works very well for most of the children. It could be implemented at home and school so that like they'll get all the nourishment, all the sensory system will get appropriate activities based on the need. And it's a planned and scheduled activity program. It includes combination of alerting, calming, and organizing activities. The main principle is the modulation effect on the nervous system. So modulation is like either you go fast or go slow. A good example, like when you're driving in a highway, like how well you drive very fast based on the need. Or even you're driving in a traffic, you drive very slow. So it's you modulate based on the need. For the children, they doesn't know. They just jump in or run anywhere. So they cannot modulate. So the sensory diet will provide a modulation effect on the nervous system so that they can understand about them and about the environment, and they can modulate the movement or patterns of things what I'm doing based on the need. It is repeated throughout the day, so the occupational therapist will give you a clear explanation when, how, and how many times can be done. It improves attention and concentration. The adaptive response are the more functional and skillful in their daily activities. So once the children has been given a planned sensory diet during the course of the day at home or school, once sensory needs are being met periodically and regularly, the adaptive response or the way they respond to functionally are very good, and they can learn new skills as well. And what are the goals of sensory diet? Like it helps the child understand his or her sensory needs, calm and over aroused or overly active child, increase the activity level of an under aroused or passive child, prevent uncomfortable reactions to sensory input, reduce sensory seeking self stimulatory behavior, facilitate optimal levels of arousal, which is really required for most of the time for learning, increase child's productivity and comfort in the environment, teach a child self-regulation strategies, which I didn't mention about the small cup, the right cup, and the big cup, improve organization of the nervous system to organize and plan, or not about the least, like we always say, like we need to provide the just right challenge to the child where the child can learn appropriately in a competing environment. This is a small sample of like which I do work in the sensory diet program. So like it depends upon the vestibular, tactile, and proprioceptive, which is the base of the pyramid. Like I give activities like linear spinning or fast spinning or slow or tactile. Like there are loads of touch related activities which I'm going to explain later. Proprioception is more like push, pull, and carry. So these are the activities which could be done during the day. So this is a small example which I really wanted to show you guys. The next one is the visual schedule. Like the child has to anticipate what are going to be happening for the course of the day. So once you have prepared a proper visual schedule, most of the speech and language therapists or in any kind of therapy setup, like they do have a visual schedule so that like the child will know. That's what like the children with autism, once they have been bombarded with like loads of activities one after the other, if they are not being intimated earlier before, they'll be like too meltdown or like huge happening with the behavioral challenges. So the visual schedule, which really helps us for the child to understand, okay, I'm going to do this first, I'm going to do this next, I'm going to do this later. So once they're prepared enough for the challenges, then they're able to really participate. So I really appreciate like most of the homes will have the visual schedule using the text and everything. So usually the visual schedule plays a major role for planning the therapy intervention as well. And next one, Lise, is the assistive and adaptive devices. Most of the time I see like children with autism are like putting things in their mouth all the time. So the oral mouth are like provide a chewy tube to chew, or incorporate crunchy foods during the snack time, or jaw compression and oral imitation games like more like blowing bubbles or like blowing with a straw, or like any type of oral imitation games are really very good for children who are having seeking oral motor device. And I also use some of the bubble gums, like there's called double bubble here, like our sugar-free gums, or even I feel like some of the children always bite at the edge of the pencil, so that like there are called pencil toppers. And the third one here, they are called the chewies. Sorry, the chewies, which are very, very effective for children who are seeking all the time. Most of the time, they drool a lot as well. So some of these ones really help a lot to prevent drooling as well. I prefer blowing bubbles, which is really very good for oral musculature activities. Blowing bubble is an excellent activity, which I really highly recommend. So some of these ones are for oral motor. For tactile, so tactile is a touch. So in body, we have something called as light touch. If I touch my skin, it's a light touch. If I keep touching more, it's pressure. If I'm putting more pressure, it's pain. So the children should have the understanding knowledge of the light touch, pressure, and pain. Most of the time I see like children have huge difficulty in sensory discrimination. They cannot discriminate the pain. There will be a small cut, but the children will come and show you, I had a big cut, I had a big cut. But there will be a child who had a big cut, and there'll be bleeding, but the children wouldn't be aware at all. So all these tactile, the touch sense is one of the major senses in our body, or you can even say that the skin is one of the largest organ in our body, which sense the environment through all what is happening around you. If the tactile sense or the touch sense is not working cohesively with the other senses, it will be a huge difficulty. That's what I always insist. Touch, pressure, and movement are the basis level of the environment, the pyramid, will be very, very essential to work on. So the touch, you have loads of activities which you can do, like basing from the home. Like the second picture shows like a normal shaving cream or shaving foam could be a great thing. But I usually say in an Indian context, our kitchen is the best therapy room ever. If you go into a kitchen, if you're cooking, like your loads of vegetables, whatever vegetables you use, you cut. Every vegetables, when you cut it off, like there's some kind of a deli-like systems, like jelly-like things, which we can use it for children with autism to work on to improve their tactile perceptual skills. Coloring games, therapy, sandbox, each and everything. Even like you put all your lentils, like whatever, like grams, you use it for cooking. You can use it in the box, put it in, put their hands in, try to mix and match so that they improve their tactile thing. Movement. Most of the time I see like parents will complain about, oh my God, like my child is always on the go, go, go. Like it's very hard for them to sit in the chair. Like how we do that? So indoor and outdoor, we can provide something called as trampolines. We can use it. But having said that, there's something called as like we have like adaptive seating. We have use it like sit and move cushion or ball seat. I use these cushions which I mentioned here for the children. That's why the basic underlying strategy is like if the child is seeking loads of movement, for example, they are like more hypo or they seek loads of movement to regulate them. So it's very hard for them to sit in the chair and to focus on any type of activity. For example, to say, in that case, what happens when we provide the movement at the base itself in terms of these cushions? So the movement is provided at the base, so they can sit and they just wiggle and giggle and whatever they can do. And the attention to the task is improved more when you provide these type of cushions. I use ball, the therapy ball, the 65 centimeter therapy ball as a cushion or a chair for them to work at the schools. So it really worked a lot for me. And like these ones are the sit and move cushion, you can Google it. This is also an amazing tool which really helps a lot for a children who is very much active. You can use these cushions in the home and school to really improve their attention to task. So the next one will be the proprioception or the pressure sense. Usually like parents will ask me like, how will you improve the pressure sense in the body? And like we use loads of push, pull and carry activities. The one which on the top is more like, pressing on something, or like it really gives appropriate input to the joints so that like they know exactly how they are moving. As I said earlier, like using a plastic cup and a glass cup, the amount of pressure required to hold the pressure is really the proprioception. Or even sometimes the children might use the pencil too much of pressure, can see they're breaking the tip all the time. Or some children using no pressure at all, they can't write properly. So how do they know that? A simple example I can say is like to take one bowl of water and to put some